Good afternoon and welcome to today's presentation, What You Need to Know About Scars. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law. Stands the expert's consent, i.e. a business relationship where she or he is hired for your particular case. In today's webinar, Dr. Zaydon will discuss case review, types of burns and injuries, scars, PRP therapy, joint pain, conditions treated, work-related injuries and compensation, and research studies and case review. To give you a little background about our presenter, Dr. Thomas Zaydon has more than 20 years of experience as a board-certified plastic surgeon and specializes in a variety of procedures. Dr. Zaydon works in conjunction with patients who have experienced trauma with resultant scars, burns first, second, and third degree, including catastrophic cases. He uses multiple skills, including scar revision, laser therapy, massage, hyperbaric oxygen, biologics, and other associated products to reduce and minimize scarring. Attendees who require a passcode, the word for today is SCAR. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you are applying for CLE credit, you must log on to your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archived recording of the webinar. The slides can be downloaded from the resource list by clicking the link at the bottom of your screen. Thank you all for attending today, and Thomas, the presentation is now turned over to you.
Good afternoon, everybody. I'm speaking to you from sunny Miami, Florida. We're enjoying 77 degrees and a humidity of 77 as well. So I wish I could do this presentation outdoors. So what do attorneys need to know about scars? Well, let's start with the basics. Scar comes from the Greek word eschara, which can be loosely translated to scab. And a scab is a mark in the body or within body tissue. Sometimes it's not visible. It's from the way the body heals naturally. So basically, scars are areas of fibrous tissue that replace the normal tissue after injury. And that's what a scar is. It's a natural way of the body healing. But in order to help the jury and the judge or the mediator understand what's going on here, it's helpful to understand not only what a scar is, but what the importance of a scar is, and discuss some of the terminology you may come upon in the medical records. So that being said, I'm going to be showing a lot of case reviews. I decided to make this more visual. These are not a lot of word slides, but I'm going to try to give you information that I believe will help your client, whether it be plaintiff or defense. The first thing I wanted to point out is that not all scars are treated with surgery. This particular girl, she was a bartender. She wasn't drinking, and she fell off a bar stool and she injured her face. And I was able to achieve this kind of reconstruction without surgery. So what are some of the things that we can do? And this is helpful in the courtroom because the jury may not be aware of the value of other modalities of treatment. Specifically, this particular girl, we used a special laser, a light-based laser, and the laser energy was applied to the scars when they were red, as you see in the middle slide. And we used some hyperbaric oxygen to kind of intensify the effect of the laser. And we were able to achieve a not only healed wound, but a healed wound with less redness. So not all scars have to be waited out. In this particular girl, just by early laser and tincture of some hyperbaric oxygen, we were able to achieve this kind of a result. Now, everybody who has a scar is always going to have a disfigurement. They're always going to have a mark. They're always going to have a blemish or discolor. Whenever the dermis is violated, whenever it is of sufficient force, the trauma, to injure the dermis, that's when you're going to have a residual. And at least in my state, scarring of the skin is considered a permanent impairment. It's considered a permanent impairment. So it's important to recognize that scars are an important part of damages. Slide. I'm going to speak up a little bit louder. Now, not all scars are due to cuts. Scars can happen from a particular patient off a motorcycle, and he scrapes his leg along the pavement. And even though the skin was not lacerated, he did sustain a scar, as evidenced by the disfigurement, the blemish, and the discoloring. Now, when you look at a scar, it's more than just cosmetic. What else is going on here? This scar is less resistant to the sun. It has fewer hair follicles. It has fewer sweat glands. It's way more than a cosmetic deformity. The function of the skin has been compromised by this, what we call an abrasion or a scrape. And it's important to understand that this scarring is of inferior quality than pre-injured skin. The texture has been compromised. It's not supple. It isn't protective. When this patient goes out to a hot environment or into a hot kitchen or any sort of environmental stressor, there's going to be a lack of protective function of the skin. So there is a disability, and it's very often I see lawyers trying to characterize this type of situation as cosmetic. And again, in a scar such as this, a great deal can be done. A lot more than just cutting and sewing. And we'll discuss that in future case studies. This poor gentleman, one of my favorite patients, is a young police officer who's at the shooting range. And he was practicing with a bullet gun. And I think it was his first day at the academy, first day at the police academy. And the bullet ricocheted and hit him in the forehead. It could have been worse, but this demonstrates that a patient, even with a facial scar, can benefit from intervention, because in this particular patient, with a combination of surgery and laser, we were able to intervene and get a good result. This demonstrates several principles. This is a scar on a wrist, and you may recognize this as a keloid scar. Now, there's two words that you may come across in reports, and I want to demonstrate the differences. A keloid scar is a scar that's more typical of on the left. This is a scar that is more serious. It grows outside the zone of injury, keloid. They tend to be itchy. They tend to be painful. And they require a great deal more intervention, which is far more unpredictable than other types of scar. As most of my audience knows, keloid scars are more common in folks of ethnic background, the non-Caucasian skin. This is felt to be due to the increased number of melanocytes, or pigment-bearing cells, that are in the non-Caucasian skin. And a keloid scar clearly is unpredictable. The feature is always guarded. If a keloid scar is simply operated upon by itself, you're going to have 45% chance of recurrence. Often, keloid scars, which are, again, more problematic because they continue to grow outside their borders, we use other modalities in addition to surgery. These include low-dose perioperative radiation. We also have used laser, and there are two types of laser, which I'll discuss in a bit. We can use steroids, but modalities that are over-the-counter, such as derma, onion skin, vitamin E, are of minimal to no value. And this is a good result after a keloid scar. On the right, this is the keloid scar been treated, and it requires multiple disciplines to get the best result. There's really no one shot for a keloid. Now, contrast the keloid to a hypertrophic scar. I'll go to the next case study. And a hypertrophic scar is not as serious. It's also due to an overproduction of collagen, much like a keloid. It's raised, and it goes above the surrounding skin, but it doesn't invade the surrounding skin. See, a hypertrophic scar grows but doesn't invade. Typically, with a multidisciplinary approach, laser, surgery, and sometimes other modalities, you can get a reasonable result. And again, in patients with high melanin levels, adverse scarring is quite a bit more noticeable. It's stiff because of the excessive collagen. It's very objectionable. And basically, you can consider either a hypertrophic scar or a keloid scar as an overexpression of collagen repair. As I said previously, collagen repair is the natural way of the body's healing. But sometimes we have to control the body's healing to get the best possible result. I want to talk about contractures. Contractures are an important part of plastic surgery because these scars indicate a much deeper injury. A contractile scar can happen whenever the entire layer of the skin has been injured. And this unfortunate gentleman had a burn, a flame burn to his neck. He lost all of the skin that was in front of the neck, and the body does want to heal, and the body does heal with a scar. But notice how this contractile scar, which is a result of a full-thickness injury, has resulted in a functional impairment. This constricting scar is deeper, and it's affecting the adjacent muscles and nerves. It's impairing his ability to look left and look right, the ability to drive a car, quite tight, and this contractile scar clearly is less flexible than uninjured scar. Now, how do we as plastic surgeons address a patient like this? Obviously, this is a devastating, catastrophic injury. There's no single solution. All the vitamin C, E, derm in the world is not going to rectify this. Well, the first principle is we want to relieve the contracture. And you may have come across the word in reports called a Z-plasty. A Z-plasty. A Z-plasty is rearranging the skin of the contracture, cutting into it and moving it into a different configuration so you can get release of the tightening. And this is important because it does not erase the scar, and in a way it creates another scar with the goal of helping this patient functionally. So let's go back to basics. Third-degree burn is a full-thickness burn. It's a most serious of all the burns, all the layers are burnt. 100% of the time leaves a scar. Contrast that to a second-degree burn, where there's blistering, typically healed in 3 weeks. There is some compromise of skin function, and if it's a deeper second-degree burn, it would be a scar. And then first degree is a simple sunburn, which typically does not scar. Again, demonstrating the seriousness of a full-thickness, third-degree burn to the arm. And most of the jury that I've educated are familiar with first, second, and third-degree burns. Most juries understand that burns are quite painful, and they understand that burns are quite disabling, and they have a great deal of empathy for burns, which is important because they are quite, they do compromise the patient's abilities to not only use a limb or an arm or talk or whatever, but they also compromise the muscles and nerves adjacent. So, again, the third-degree burn is the most serious. Yes. Third-degree burn of the hand, again, a hand obviously is important in everybody, and it's important to document the diminished function in this type of a burn of the hand. So we see a great deal of scars afterwards, after the patient's been repaired. And my job as a plastic surgeon is to document the severity of the scarring. I tend not to get too involved with how it happened unless it's important for the diagnosis. But I want to explain the impact that a scar has on the claimant. We do know that scar is a natural part of healing, but it does have a big impact on the patient's quality of life. And very often, in this patient who was stabbed at a gas station, my job is to photograph the scars. We're a very visual specialty. Document the impact that it's had on the patient's ability to do whatever activities have been compromised. If the scar is in a visible area, to document that the patient may or may not be suffering from lack of self-esteem. And this is important because most patients who are presenting to me with a scar, whether they mention to me or not, have some diminishment, some compromise of their sense of self-worth. And if the scar is visible, even more so. So I mentioned to you that your plastic surgeon may not diagnose this condition, but certainly he could or she could allude to the fact that it is not unusual in a patient with scars to have a compromise of their self-esteem. Taking things one step further, I wanted to mention that it is well documented that two patients, two prospective employees, equally qualified, two equally qualified patients, clients, employees, the ones that don't have the scar are going to get the economic advantage. It's been well documented, whether the scar is visible or not, that economic outlook is compromised in patients with scarring. Obviously, the more extensive the scarring, the more the compromise of the outlook. Now, this demonstrates now a burn scar in the lower extremity. And this leads me into my discussion of what is my approach to scar. The first thing is, number one, to observe, to listen to the patient about the complaints, to elicit any complaints of itching or burning. to see if there's increased symptoms when they push on it. Ask them how they feel about it, make it an open-ended question, and not to jump in immediately to surgery, because a scar such as this is more amenable to non-surgical approaches, and we call them manipulative. We manipulate the healing process so we're able to get a better outcome. And in this particular patient, I would recommend laser. There's two types of laser for folks that are taking notes. One is an ablative laser, and the second is a non-ablative laser. Ablative and non-ablative. An ablative laser is, for example, what we call a CO2 laser. It's a more aggressive unit, and what it does is it recreates the wound, and then the healing is a more controlled, smoother healing. The collagen is disrupted, but then lined up in a orderly, parallel fashion. A non-ablative laser would be a light-based laser, which is more gentle. And so in a patient such as this, he would not be approached with the scar revision. He'd be approached with manipulative strategies. And very often, plastic surgeons overlook manipulative strategies. Now, I'm often asked if burns can turn into scars. There is some older literature that burn scars in the lower extremity are pre-malignant. However, the more recent literature says that is not true, and it is probably not true that keloids become malignancy, and it's probably not true that hypertrophic scars become malignancy, and probably not true that burn scars become malignancy. There's still some controversy, but with each passing year, more and more articles are coming out demonstrating that scars are not associated with malignancy. This gentleman, poor guy, and I see a lot of this. The fingertip is probably the most, obviously, people use their hands, and the fingertips are the most commonly injured part of the body. And what this patient came in with is not a dead finger, but after the slicing off part of his finger, they put it back on, and it didn't attach. So this leads to a principle in plastic surgery, which is if something's no longer alive, we would what we call debride it. Debride it means that it's surgically removed down to the level of healthy tissue, and by doing so, one is able to control the healing in a fashion that is less likely to get infected, because if something's not alive, it might get infected, and number two, heal with a much better scar. So basically, my job as a plastic surgeon and seeing any of these types of injuries is to control the healing process to the best of my abilities. So in this particular patient, our principle is to remove the skin that's no longer alive and resurface it in a controlled fashion. Again, another example of a scar. This is very interesting. You may come across this word in your reports called a compression syndrome. This is an arm you're looking at. This arm came into the emergency room with very swelling appearance, a very swollen appearance, and there was a compromise, a lack of circulation. And in order to relieve the swelling and restore the circulation, it was necessary to make a splice into the arm to relieve the pressure. And this, of necessity, resulted in some degree of scarring. And as we see more and more Ubers, we're seeing more and more people involved in those types of incidents. So in a scar such as this, the approach would be early manipulative, which is laser and the like, and then later you would go ahead and in stages remove the scar bit by bit. Very often, your clients may come into my office and they may show me one scar related to an accident, but there may be another scar that they forget to show me. So remind your clients to show their plastic surgeon all the scars. Now, even if the scar is not related to the reason they're there, it gives us an idea how they heal. Now, here you can see this gentleman is healing with hypertrophic scar. So his prognosis would be more guarded than a patient that's not healing with hypertrophic scar. And, you know, you wonder how a sink incident can cause a buttock injury. What happens is the sink collapsed in this guy, and then the guy fell to the ground and lacerated himself on a broken piece. Now, even though the buttock scar is not visible, it is amenable to reconstruction. It's an important part of the damage evaluation. Okay, so we're now at the halfway point. I'd like to take some questions and answers.
Now we are entering the Q&A session. During this time, please enter the passcode in the Q&A widget. The passcode is SCAR. Also, enter any questions that you have for Dr. Zaydon as well. First question we have is, can lasers be used to minimize scarring from skin grafts, donor site or site of the actual burn?
Absolutely. Lasers, again, are ablative and non-ablative, and there's evidence in our literature that laser energy is of benefit. How does it work? Number one, it restores the pigment cells to their pre-traumatic functioning. Number two, the lasers help smooth the collagen. It actually recreates the injury so you get smoother collagen. Number three, the light-based lasers eliminate inflammation, and inflammation is the enemy of good healing. By minimizing the inflammation, minimizing the redness, the induration, one is able to soften up the scar. So again, there's two types of lasers, ablative and non-ablative, and they both have different uses and both have different risk-benefit profiles. Okay. Next question.
Okay, the next one is 5-year-old girl attacked by a pit bull, nearly tore off her right cheek. Currently healed with scarring along upper cheek and along chin. What future surgeries will she need to get the best results for her mature improvement?
Okay, in this particular girl, we don't do scar revisions, surgical, in children. The only indication to do scar revisions is when there is distortion of the adjacent anatomy. So as the child grows and we see that something's not growing properly because of a scar, then we might intervene. Now, we could do laser. There's evidence that the gentle laser, the light-based laser, may be a benefit in children. In fact, I would say I offer this to the majority of my children that come into my practice because there's evidence that it makes a big difference. Now, it also is important that the child is to be followed periodically. This child should be seen once or twice a year by the dermatologist, plastic surgeon, or pediatrician to be sure there's no distortion of the adjacent soft tissue anatomy. These follow-up visits are an important part of evaluating the damages. And lastly, we have to think about the future down the road when this child is more fully grown, age 16 to 18. At that time, more likely than not, the child will need multiple procedures to get the best result. Now, it's important to understand that it may not be a one-shot deal. It may require a series of operations. And whatever estimate the plastic surgeon gives has to be adjusted for possible inflation and possible changes in medical costs. Now, we're not economic people, but we also don't see the cost of today being the same cost of tomorrow. So this was a more of a devastating type of situation because we're looking at multiple interventions over the patient's lifetime. And also juries clearly understand, and this is very, very, I see this all the time. Maybe it's obvious to us, but sometimes we should understand it's obvious to juries. A scar in a young woman has more of economic impact on her social life, her future, her married life, her employability, than a scar on an older person, someone aged 60, 70, 80. Juries are not going to come back as high. And in jury selection, really quickly I wanted to mention this. I have found that the older juries and juries of veterans, this may seem obvious, but I've seen this over and over again, are not as empathetic toward scar victims as the younger juries. The younger jury members are more emotionally impacted by a visible scar in a young woman than an older jury would be. Okay, next question.
Next question. How does oxygen work in healing scars, and can oxygen alone completely do away with the scar?
It will never go as scar. Every scar is permanent, and what oxygen does is it helps to minimize inflammation, lower the white blood cell count, and by doing so, it helps get less erythema and redness, which is pro-healing in a controlled fashion. Well, I'm happy, believe it or not, I'm told there's a great deal of questions. If you could email them to myself or to TASA, we'd be very glad to answer them. But I wanted to get through some more of the material here, and then we'll take some questions at the end. So please don't hesitate to contact us. Let's talk a little bit more about keloid scars, because most juries want to know more about them. Here, the fibrous tissue, and it is fibrous, it's hard, it's woody, has replaced the normal scar after injury. And as they mentioned, it's more common in non-Caucasian skin. And this scar, we use something called low-dose preoperative radiation therapy. It's an expensive modality, but it is of some benefit. There's a theoretical risk of occult malignancy, not from the keloids, but from the radiation. And what we did for this fella, and this is long-term follow-up, is we removed the keloid. Again, if I remove it without doing something else, 45% chance of recurrence, and then we were able to use low-dose radiation to minimize the chance of recurrence. It started immediately after surgery, or certainly within 24 hours, and the protocols are either 2 low-dose treatments, 3 or 4, depending upon the center. And although it's quite costly, it is quite effective in controlling keloid scars. I would not use it over a cancer-prone organ. I would not, if someone had a keloid over a woman's breast, I would not use it in that zone, although some radiologists feel differently. Again, the definition of a keloid, it grows outside of its normal zone. This is also very, very interesting, and I see this in plastic surgery, and it's sometimes overlooked. This woman has a scar on her foot. Okay, well, what can you do? Well, she's an older woman, you do some laser, you could do some oxygen maybe, you could do some injections, either topical or maybe something, to rub on it, maybe operate on it. But here's the problem for this lady. This lady can't walk. She used to enjoy her morning constitutional. She used to enjoy getting up and getting out there and walking. She was known to walk 1-2 hours every day. In fact, she was in a neighborhood where it was customary to see her every morning, weather permitting. Well, she had this, she was at a local department store and foot accidentally got lacerated underneath the corner that was sharp. And in this woman, who is an older woman, it had a big impact on her because she wasn't able to exercise freely anymore. And she developed a medical condition which was exacerbated by her inability to exercise more freely. So it's important that the court understand that there's more than just a cosmetic implication of a scar. They need to understand what can be done, and the cost, the prognosis, the diagnosis, but they need to understand the impact that this scar may have on someone's everyday life. And I can put that in a sentence or two. The patient became diabetic at the incident because she can't exercise. But this is something for the jury to understand. Now, I wanted to give some defense-oriented remarks in case there's some defense people listening in. This fellow was at a barber shop, and I'm going to give some defense information with this case study. And he's trying to get a haircut, and instead of getting a haircut, he got a chin cut. We've seen a fair number of these barbershop incidents. It's not that unusual. And, you know, obviously it's a scar on the face, a kid. What are some things that you could ask the plastic surgeon in the deposition if you're from defense? And these are very good for both sides to know that these are anticipated questions. Most scars, after treatment, and some with or without treatment, the natural tendency is to improve until the end of the patient's lifespan. Obviously, the exception would be a keloid or hypertrophic. They may not have such a good prognosis, but the natural history of a scar is to improve. We're not magicians, but we can do a great deal for scars. And in general, the results of scar management, both manipulative and surgery, are generally good. Obviously, you can't argue about the scar. It's there. Everybody can see it. But one wonders how you come across the costs for scars. Well, repair them. Well, in our literature, we have what we call ICD-10 and CPT. ICD-10 demonstrates the definitions of various scars. And the CPT, current procedural terminology, demonstrates the codes. There are 5 numbers. And by assigning an ICD-10 and a code to a scar, you can come up with a reasonable estimate for future care. Very often, plaintiff-oriented plastic surgeons, regrettably, have been very aggressive in their pricing of future surgeries. So it's important to ask your expert where he got this information and where the operation is to be performed. Where and when is certainly important. Finally, it's important to recognize that not only is the price subject to change, it can obviously be negotiated or discounted for prepayment. Even in our medical system here, our hospital, my chief of plastic surgery at my hospital, if a patient comes into the hospital and is paid in advance, they get substantial discounts for prepayment. All of the old medical bills need to be reviewed closely, utilizing ICD and CPT nomenclature to be sure that the billing is part of the relative value fee schedule. It's called RVS. We assign certain values to certain services, and they're pretty standardized. So keep that in mind if you're planning for defense when you're looking at future costs. Very often I see people jumping a lot of material. We look at people with glass in the forehead, for example. Obviously, if you see a scar, but the general tendency of glass in the forehead is to come to the surface. It generally does not go deeper to the heart. In this particular patient, if this glass does not come closer to the surface, it would require a reoperation for removal. It's typically not removed just to remove. It's typically only removed if it's painful or symptomatic. Gunshot wounds and scarring are always catastrophic, almost always catastrophic. A bullet, unlike a knife, wreaks much more havoc on the body. Almost always, a bullet wound implies damage to adjacent structures or organs. So a gunshot wound is typically an explosive injury where there's a lot of collateral damage. Contrast this to a knife wound where the damage is more controlled. So the damages in a gunshot wound are quite a bit more considerable, and they may require imaging to understand the extent of the scarring. It may require an MRI or ultrasound, sometimes a CT scan, because there's a lot more than meets the eye when you have a gunshot wound. Again, demonstrating that a third-degree scar is a more devastating injury. Let's talk about airbag burns. Very interesting. Now, airbag burns do cause scars. We know that. They're frequently overlooked. I get these cases from orthopedic surgeons, sometimes from chiropractors, and just a little change in the color of the skin. No big deal. Go away with time. An airbag burn is due to, number one, the release of noxious chemicals. Number two, it's due to a contusive force. I'll move on here. Contusive force. It's due to a impact of great force and magnitude, and the changes are, even though at first glance they look trivial, they do cause significant changes in the function of the skin. And by doing so, this really is something that needs to be described by a plastic surgeon. Frequently overlooked, airbag burns are part of damages and they should be evaluated. I don't have a slide that should demonstrate this, but an airbag burn over a previously placed breast implant usually implies that one should evaluate the integrity of the implant, make sure it's intact, and also if it's been displaced from its pocket. So as lawyers, please think in three dimensions. There's more than meets the eye, and what meets the eye is far more than the cosmetic. Incidentally, the definition of cosmetic and reconstructive is very important. I'm often asked in depositions, is this a cosmetic injury? And I answer, I believe correctly, it's reconstructive. Cosmetic is an aging face, you do a facelift. Cosmetic is doing any sort of lifting procedure. And reconstructive, it's taking a normal person who has been injured and putting them back to normalcy. So cosmetic refers to elective, there was no accident. Reconstructive, by definition, is you're repairing, there is consequences of trauma. Boiling water here, as I mentioned previously, caused a second-degree burn, which is most typical for boiling water. The blistering, and this should be healed in 3 weeks. Typically, if it's not healed in 3 weeks, it indicates a deeper burn. The deeper the burn, the more likely for scarring, and a deep second-degree burn does result in some degree of scarring, redness, change in skin texture, loss of follicles, loss of sweat glands, and changes in skin color, disabling. Again, another example of a hairstylist off target, and please note that not only was there a laceration, there was a abrasion. The scissors not only caused a piercing of the skin, but there was collateral damage. be sure that your plastic surgeon evaluates the collateral damage. Just other examples of things that we see. This dog has a cut on his head. This demonstrates a scar that has a sunken appearance. This is in contrast to keloids. This is in contrast to hypertrophic scars. Think three-dimensional. So this guy came in with a scar on his scalp. Okay, sunken. Guess what? I think three-dimensional. I got a CT scan, and there was a defect in the cortex. All of a sudden, what could have been a simple office scar revision turns out to be an inpatient case in the hospital to restore the bony contour. Think three dimensions. And don't believe that the medical records from the emergency room or the hospital have diagnosed the entire extent of the injury. So I'm going to move along real quickly here. Scars are a normal consequence of wound healing. As my colleagues in law know, they're often an issue when damages are related in a medical legal forum. As a plastic surgeon, I'm called in for both plaintiff and defense to diagnose, give a prognosis, estimate of future medicals, a sense of the permanency, to educate the jury, educate the mediator, educate the judge. I really enjoy this type of work. It's fun to teach. Fun to teach you all today. Let's talk about PRP therapy. This is very, very, very exciting stuff. For our older audience, PRP may be a shot at a higher quality of life. Platelet-enriched plasma. This may be our shot at healing arthritis, but we're using it for many reasons, not just like some of the sports figures for their bad knees. We're using it for scars, believe it or not, and it's become on label. The original research was actually done by the military. We had returning veterans from Afghanistan, and they had these devastating burn scars. And we found if you take one's own blood, and you spin it in a centrifuge, and you separate it into its various components, you can take this blood that's been separated, the healthy plasma cells and the healthy stem cells, and I'll get back to in a second, and inject them into the scar, and I'm going to show you some incredible results. Now, what is a stem cell? If you remember from our high school biology, stem cells are the embryonic cells. All cells start as a stem cell, and they evolve, and they become a mature cell later in life. And these stem cells have a lot of good factors in them that can be used to lower inflammation and improve the quality of a scar. They also found in a baby in the umbilical cord, very, very rich in stem cells. We have used stem cells in our practice for many, many things. I had a lady who had a airbag injury to her forehead. She had lost hair follicles. Stem cells and PRP was utilized to restore hair follicles. Now, fat grafting is closely related to stem cells. Now, fat grafting is taking one's own fat from one part of the body and transporting it to another part of the body. Now, this is evolving technology. In fact, in our latest, what we call the White Journal, Plastic Surgery, the very last article was an update on stem cells, fat grafting, and PRP in scar tissue. And the early results, early evidence is that it is beneficial. Now, you're going to get a little bit of pushback on this from the defense because it's still not quite widely accepted, but it's evolving. And it's certainly something that I've used in my own patients with good results. and I would anticipate we'll know a lot more in the very near future. The PRP is also used to release contractures, such as that neck burn I showed you. And outside my field, for those that are interested, it's been used for arthritis, nerve pain, acne scars, and other chronic conditions. I just mentioned, I don't know if there's workers' comp lawyers in the call, but workers' compensation, I always mention that early management of these claimants, aggressive management by the nurses and by an interested doctor, can get the patient back to work a lot quicker. But scarring in our state is reimbursable by workers' comp. It's not cosmetic. And I mentioned that in work injuries and scarring, active management, very often a good repair of something may lead to a better long-term result and less necessity for secondary surgery. So whether someone has a burn, whether they have an abrasion, whether they're in the hospital, out of the hospital, early treatment by a qualified individual leads to a more optimal outcome. So to mention that, because I mentioned that's a good way of mentioning good case management. And this demonstrates the value of PRP in scar regeneration. I'll leave some time for questions. Outside this talk, this is a sports figure who had complete resolution of his osteochondritis after PRP injection. And as I mentioned, the research studies are actively underway, but as recently as this month's Plastic and Reconstructive Surgery Journal, the White Journal we call it, promising information is coming about PRP and stem cells. So I do a lot of case review. I enjoy it. I enjoy teaching. I enjoy talking to lawyers. I really love educating the judges. It's important that you have an expert that is balanced. You have an expert that sees things kind of clearly, doesn't think in one dimension, someone that has empathy, yet someone that doesn't go off on a wild tangent. You can ask your expert, this is important for the defense, are you aware that your testimony is being peer reviewed? In my society of plastic surgeons, we have a code of ethics. It's on my website. And if you give what we call fake testimony, I guess first cousin to fake news, you can be sanctioned by your board and actually lose your credentials with the board. So if you have an expert or a so-called expert or a fake expert that is absolutely ridiculous with their estimate, I'd ask him or her, are you aware that this can be peer reviewed? Are you willing to have this, reviewed by your peers, not just by the other side's expert, but by your peers? Because this in our field, we want to keep the science in the field, we want to keep our credibility high, our stature and ethics at the highest possible level. So in that regard, I'll leave a few minutes for questions. We're almost out of time. Do we have any other questions that I can answer now?
We are once again entering the Q&A session. Once again, please enter the passcode in the Q&A widget. The passcode is SCAR. Also enter any questions that you have for Dr. Zaydon during this time. Please remember that if you are applying for CLE credit, you must attend for the full 60 minutes of the presentation. You are also required to complete the survey at the end of the program. First question we have is, how do you go about evaluating the permanent injury to a burn patient who you first see 2 years or more post-injury? Second-degree burns to hand from steam, treated with hyperbaric at a burn center. Successfully returned to work within 6 weeks.
In plastic surgery, we start with the good history. We want to know how this affects their daily living. We want to know how long we're in the hospital. If you have a sense of how long something took to heal, you can get a sense of how bad the burn is. Obviously, the longer it took to heal, the worse the burn. You want to see what they can do and what they can't do. Then, after you take a thorough history, you do a physical examination. This consists not only of looking, but of touching, not only of touching, but measuring. You want to measure 2-point discrimination. You want to examine closely to see the function of the sweat glands. You want to examine closely to see the texture. You want to look closely for any even slight decreases in mobility. You want to look for changes in skin color. And it's just a lot more than a casual observer would glean. Then you want to think in 3 dimensions. You look for damage to adjacent muscles or nerves. Has there been diminished 2-point discrimination? Has the nerve been at all compromised, both sensory and motor? How many there's a sensory loss associated with the deeper burns? And even a deeper burn can cause a motor loss. Then you want to evaluate for atrophy. Has the burn diminished mobility caused the muscles to shrink? So that would be an important part of the person's day-to-day functioning. Then, and think in 3 dimensions, you may want to document with MRI, CT, or other studies. Then you make an assessment, and with your assessment, you review the literature in terms of costs, CPT, ICD, RVS, and then you make a plan, which is the techniques and timing of revisional surgery. Okay, next question, please.
Do you see a growing number of patients with scars due to medical spa treatments done by non-medical personnel?
Absolutely. As more and more of these treatments get done in more and more places, I am seeing the wrong laser used for the wrong indication. Frequently, I've seen the wrong laser. I've seen what's a so-called hair removal laser being done with an ablative laser. It's absolutely ridiculous. In our state, there is some oversight of operators, but in some states, the operators operate without oversight, and it's the Old West. I'm seeing a tremendous number of injuries from people who use the wrong laser for the wrong reason, or some of the most ridiculous things, over-treating, burning patients. It's a pretty bad problem. In our state, the majority of these are supervised by physicians, and we don't see quite as many, but we do see a lot. Okay. I think we have time for...
Next question.
Yes.
15-year-old female involved in motor vehicle accident. Vertical laceration down middle of forehead resulting in oblique scar 3.5 centimeters long by 2 millimeters wide. What type of revision procedure would you recommend, and what code would this scar be given?
I'd have to see it, but I would probably give this a 140, and probably it would need 2 procedures, and the costs for these are well standardized, and sadly, even after optimal reconstructive surgery in time, there's going to be some degree of permanency, best case scenario. And obviously it's in a visible area in the young woman, so the jury will understand that has more of an impact. Well, in our final minute, I wanted to tell everybody I've enjoyed speaking with you. Please, I love being interactive.
Dr. Zaydon, we have a few more questions that we would like to ask from the audience.
Okay, we only have 1 minute, but I'll be glad to. Go ahead.
Okay, next question. Child has 2nd-degree burn marks from hot coffee. Can you tell from the pattern of a burn scar whether it was caused by an intentional immersion or whether it was an accidental spill?
Okay, you have to ask whether or not the person was wearing clothes. Sometimes a person either spilled, accidentally, intentionally. This comes up all the time under liability. You need to know what they were wearing, because the clothes can act like a insulator. And I mentioned to you that very often people overlook the fact that if you don't take off your clothes after a hot burn, it continues to burn. So if anybody in the audience ever spills something on their jeans, don't think your jeans are protecting you. They're probably making it worse by potentiating the burn. So you can look at the pattern and surmise, but this is frequently litigated, the liability, whether it's intentional or not. I think that's our 1 hour because we're being recorded.
Yes, that was our last question. Thank you.
Please.
In addition to being your best source for testifying and consulting experts for the past 60 years, TASA also offers e-discovery and forensic solutions, free interactive webinars, day-in-the-life videos, research reports on expert witnesses, such as Challenge History Report 2.0, Professional Sanction Search, and Expert Profile 360. I want to take this opportunity to thank everyone for attending, and most especially Thomas Zaydon for his time and effort in creating this presentation. If you would like to speak with Thomas, or if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. This concludes our program for today.